All right, good morning, everyone, and welcome to day two of the conference. It is a pleasure to welcome you to this virtual session dedicated to advancing our collective understanding of pediatrics, child health, and gynecology. Today's program will bring together distinguished clinicians, researchers, and emerging professionals who will share valuable insight across a broad spectrum of topics, including pediatric endocrinology, ophthalmology, behavioral health, gynecology, and surgical management. Since Dr. Gerald is ready, we will begin with your presentation. So join us in welcoming Dr. Gerald H. Katzman from Wayne State University of Medicine from the U.S. His presentation title is The International Century of the Child, Is It a Dream? Please join me in welcoming Dr. Gerald.
Thank you very much, and thanks for having me. I'm going to start by sharing my slides. Let's see where we are here. There we go. This one. Okay, can everybody hear me? Yeah. Well,
Yes.
thanks again for having me. And yes, the topic of the discussion here will be the International Century of the Child. Is it a dream? Why does humankind need it? How do we get there globally? We're going to look at an overview. We're going to look at childhood maltreatment globally and approach to remedies. Now, the General Assembly, I need to minimize this. The General Assembly of the United Nations passed a proclamation designating 1979 as the International Year of the Child under the auspices of UNESCO. The idea was to draw attention to and hopefully address problems that impacted children around the world. As a consequence of this effort to provide support to children in need, a new document was drafted called the Convention on the Rights of the Child, the CRC. The CRC was adopted by the UN General Assembly in 1989. Subsequent ratification of the CRC by all UN members except the United States has occurred. The USA representatives in the Senate expressed concerns regarding an interference in sovereignty and control of parenting decisions. So the CRC has never been brought up to a full Senate vote in the USA. Unfortunately, only UN members who ratify the CRC are eligible to be members of the CRC Oversight Committee, the OCCRC. The role of the OCCRC is to evaluate progress made by members in addressing the needs of children and to make recommendations as to how the rights of children can be better served by individual states. The fact that many impediments to the psychosocial and physical development of children persist throughout the world is a testament to the work still waiting to be accomplished. A listing and explanation of some of these critical problems that adversely influence the growth and development of children is in order to document areas where much more effort is clearly needed. We'll start with child labor. Child labor is the exploitation of children through any form of work that deprives them of their childhood, interferes with their ability to attend regular school, or is mentally, physically, and socially and morally harmful. As of 2023, in the world's poorest countries, 1 in 5 children was engaged in child labor. Poverty and lack of schools was considered the primary causes. UNICEF notes that boys and girls were equally involved, but girls often were doing unpaid household labor. UNICEF and the International Labor Organization estimated 168 million children worldwide were involved in child labor. This is a picture of a little girl who's picking cotton and out in the midday sun, and not a good situation. Next, we're going to discuss briefly child labor and slavery in the chocolate industry. Chocolate is a product of the cacao bean seen mainly in Western Africa, Asia, and Latin America. Cocoa produced goes to companies who make a multitude of end products. Chocolate companies are aware of child labor, human trafficking, and slavery in harvesting and initial processing of the cacao pods. Cacao farmers are way below the poverty line in their earnings. Child labor was used to keep the price down, while end products result in huge profits for manufacturers. Traffickers are known to abduct children from countries next to the farms. Traffickers often tell victims and their parents that the job pays well, but hide the poor living conditions and lack of schools and dangers of work. Most of trafficked children are between 12 to 16 years of age. Long work hours, climbing cacao trees, cutting down the bean pods, carrying the heavy bundles of pods through the jungle. At a base, pods are cut open to harvest beans with great danger of exposure to insecticides. Some corporations have tried to develop inspections of the farms. Lack of inspectors and enforcement of reasonable standards have made corporate efforts ineffective. Certifications are often misleading. This shows a child using his machete to cut down a cacao pod. And this shows when the pods are open, and those are the cacao beans ready to go to the companies making the chocolate bars. Okay. Another problem is that of corporal punishment and psychological abuse of children. Corporal punishment and psychological abuse, shaming, coercion, intimidation, etc., have been used by parents and teachers to, quote, discipline children. Parent purpose of the corporal punishment is to the result in physical pain, deter similar behavior in the future. The problem with corporal punishment and psychological abuse is the production of fear and anger, which is repressed and serves as a source of negative mental energy that may be expressed in antisocial and violent activities in later years. When the child works daily to avoid the insults by caregivers, there is little opportunity to experience trusting, supportive human relationships. Frequent result is a stifling of emotional empathy and participation in violent activities a society may promote through false narratives, apparently as a result of disregard for pain inflicted on others. Corporal punishment and psychological abuse traditionally occur with authoritarian parenting. An antidote is authoritative parenting, where trusting, supportive relations between child and caretaker are established. Authoritative parenting involves establishing interpersonal attunement, teaching reading skills early, the modeling of caring and helping behaviors, and usually in the school system, human relation programs for children. Parenting teams pre and postnatally may be organized where authoritative parenting is not the rule. Now, the teaching of hatred to children. See, we have a little interference in this slide up here. See if we can get, there we go. Now, hatred may be defined as intense ill will, a great dislike or aversion, enmity or malevolence. Well, there's a well-known link between learned hatred and resultant violent speech and actions. Teaching of hatred represents a special form of psychological abuse propagated by families, institutions, and some countries. Kieran O'Hagan has defined psychological abuse as the sustained inappropriate behavior that damages mental processes of a child, such as intelligence, memory, recognition, perception, attention, language, and moral development. Oh, the slide's not changing. Let's try this. There we go. Now, the result is a false belief that may manifest itself in violent actions against an individual or a group so targeted. Thus, hatred represents a character trait, a vice, that unleashes mere self-interest, so one ignores or fails to see or consider the interests of others. If peaceful societies are our goal, then nonviolent conflict resolution and other virtuous traits need to be promulgated. Traits such as tolerance for and appreciation of individual differences and reverence for the value of human life are desirable. This is so because virtues blunt mere self-interest so that one can see and promote the interests of others. And as a vice and counter to the values that most civilized people consider virtuous, the teaching of hatred to children is immoral. Consequently, such children suffer an arrest in moral development that fulfills the definition of psychological abuse. Exposure to authoritative parenting, modeling of caring behaviors, helping behaviors, early literacy, reading stories with a moral, and human relations programs for children could prevent the development of such hatreds. Using the law to outline the teaching of hatred, thwarting hate and violence in the media, and cooperative efforts in the community would likely be helpful. Now, child soldiers is the next problem we're going to look at. Thousands of children are serving as soldiers and in other capacities in armed conflicts around the world. Service involves either government military groups or armed opposition groups. Children may fight in front lines, participate in suicide missions, and act as spies or messengers. Although not necessarily combatants, girls may be forced into sexual slavery by militaries. Many children are abducted or recruited by force. Other children join out of desperation, thinking the armed groups offer a better chance for survival. Child soldiers who survive conflict often suffer from psychiatric disorders such as depression and PTSD. Poor literacy often is seen and contributes to high incidence of poverty and unemployment in adulthood. Alcohol abuse, increased suicide rate, and violent behaviors are often seen after enlistment and training to fight, even if not in combat. Beginning in the 1990s, treaties were drafted to reduce the use of child soldiers. Treaties have not eliminated the use of child soldiers. Even some economically powerful states still train adolescents for military service. So in a number of countries, the use of children in armed conflict, terror groups, and insurgencies continues. Thousands of children are either compromised or killed as a result of their recruitment to participate in armies and militias. Clearly, the treaties themselves are not the answer if mechanisms of enforcement are not in place. It just shows a child with an assault rifle. And one of the things that have developed in recent decades is these assault rifles are rather light and children can carry and use them. This shows that like a 3 or a 4-year-old who is being indoctrinated from the word go. And this shows a little girl with a assault weapon slung on her back. Okay, well, the American Academy of Pediatrics has looked at children in armed conflict settings and seen how that affects them. Of course, there's physical violence and injuries, sexual and gender-based violence, child separation from parents, abduction and trafficking, and children become associated with armed groups and they may be detained, there may be detention when they're actually victims. Food insecurity, limited access to water, sanitation, and hygiene, denial of humanitarian support, targeting of schools, child care centers, so schooling is interrupted, and play areas, disruption of education, mental health considerations, exposure to harmful substances, grief and loss, and the need for resettlement. This again is from the American Academy Pediatrics policy statement. And of course, children, there's nothing good to say about the effects of conflict on children in these conflict settings. Global poverty, hunger, malnutrition, and starvation. The World Health Organization defines poverty as when individual or household income is below what is needed for sustenance. Poverty is often associated with food insecurity and poor access to medical care and education. Poor literacy, unemployment, inadequate housing, and poor sanitation are common. Unfortunate choices may result due to the struggle to survive. Children and families with poverty suffer high morbidity and mortality from infectious diseases and food insecurity. The scenes of such starving, malnourished children have been depicted for decades on television and resulted in successful fundraising by NGOs. Some countries and religious institutions have also provided support. The great need has not been adequately addressed. It is estimated that more than 3 billion people in the world live in poverty. There is loss of potential from lack of education and the malnutrition. It's estimated that malnutrition is responsible for about 1/3 of all deaths in children less than 5 years of age and causes intellectual impairment in many survivors. A recent study showed that malnutrition at 3 years of age was associated with poor cognition at 11 years of age, independent of psychosocial adversity. So it's apparent that good nutrition in early childhood should enhance long-term cognitive development and school performance. Global warming leading to food insecurity. This, of course, is a problem that's much discussed. It's associated with the food insecurity, climate shocks like droughts, floods, kill crops and the livestock, degrade soils, damage infrastructure, and drive up prices. Result is often conflict, displacement, and mass migration. People will not stand idly by when they cannot feed their families. If the average global temperature goes up, there's going to be many more problems with food availability. Lack of concerted efforts to decrease fossil fuel is an issue that is being addressed to some degree. So we see there's many problems, and of course there are more problems than we have time to talk about today. But we need to go forward with a plan for the International Century of the Child. Now, John Locke famously introduced the theory that the human mind at birth was a blank slate except for innate reflexes, the so-called tabula rasa. Therefore, it is one's experiences and learning that results in knowledge, beliefs, morality, and other emotional and cognitive faculties. This is largely still a valid theory today. So we need to promote a path leading to optimal physical and psychosocial development. The path should lead to benevolence, helping behaviors, constructive activity, and skills for nonviolent conflict resolution. Leaving a century to obtain this goal would seem reasonable, if not interrupted by human-made disasters. We need an organizational structure for the plan, and fortunately, the UN Oversight Committee for the Convention on the Rights of the Child is in place. Lack of participation of the USA in the OCCRC is a stumbling block. Interference in sovereignty, as I mentioned, and lack of freedom to parent were given as reasons for non-ratification by the USA Senate many years ago. This is really a poor argument. Children's rights are protected through laws and agencies in the United States, and there's ongoing improvements that continue. In the USA today, there are few interferences in culturally appropriate parenting. Reasonable concerns for aberrant parenting have been scrutinized for years in the United States. Presently, there are child protection teams in the USA that respond to reports of child maltreatment. Indeed, a pediatrician may lose his or her license to practice for failure to report suspected child abuse in the United States. Lastly, there is evidence that children are often maltreated in countries that have ratified the CRC. Only by objectively evaluating the situation in each participating country is progress likely to be made. That work to address the various problems need to be supervised by the OCCRC and individually pursued by local groups. Now, advocacy for children's rights and support for psychosocial development is very important to push these programs forward. You can write legislators, organize groups, impress them with people with the importance of the subject, child rights, early literacy, healthcare, etc. Publications as books, videos, pamphlets can be used to further and develop programs. Research studies with findings transmitted widely in understandable terms to highlight the problems for all readers can be very effective. Listening to the complaints of children, their caretakers, and teachers can be important too. One can join advocacy groups or form new ones. Public events can be organized with song and dance, highlighting causes and solutions. Peaceful, organized demonstrations advocating solutions to issues is also another approach. A long-term plan is needed for promoting optimal psychosocial development globally. Components of such a plan for all children include authoritative parenting, modeling of caring and helping behaviors, early literacy, reading books with a moral, and the teach a lesson and human relations programs. Negatively impactful issues such as armed conflict, food insecurity, and weather extremes, etc., must be addressed. Governments, NGOs, and the public need to provide the resources and personnel. The goal of a more peaceful world and an enhanced quality of life for millions of people should provide the impetus for developing and delivering the required programs. If nations could come together, will it, and work on it, it will not be a dream. So that's the end of my presentation. We just need to stop the share.
Thank you for your great presentation. It was very engaging and very insightful. And I want to open the floor to any questions. And we also do have a question for you, Dr. Gerald. Why is child labor considered an international vision?
An international problem?
Vision.
Well, I mean, child labor occurs internationally. It's similar in the chocolate industry. By using children, the cost of the raw product goes down, and the children obviously are poorly paid or not paid, and the end people, the corporations, make $1 zillion. So I think using children in a way that children should not be used is the primary issue, and why authorities and governments who care about their civilian population should be doing something about it.
Mhm. Especially all of those big companies, like I know I've heard of like Nestle, they use a lot of, this whole thing went on that they use children for labor. So I think it is something that's very important to discuss on the international level.
And this is where the Convention of the Rights of the Child should come in.
Mhm.
Uh, Unfortunately, it's been around for a while, and there's still a lot of work to be done.
Mhm. Okay. Does anyone have any other questions for Dr. Gerald? Okay.
I
All
would
right.
just
Thank
add
you
one more
again.
point. There
Go
was
ahead.
another paper entitled Child Development Leading to the Pursuit of Virtues and the Avoidance of Vices that I've made a YouTube of that. And also this International Century of the Child. There's also a YouTube available. I handed the links in, and hopefully that'll be distributed to all participants.
Okay. All right, we'll make sure that that happens. Thank you again.
And
Um,
thank you for having me.
of course. Now we're going to move on to our next speaker, who is Dr. Mariam Sharif Muhammad, consultant gynecologist from Cyprus. Her presentation title is The Vulva as the Immunological Active Organ, Clinical Implications at the Interface of Dermatology and Gynecology. Please welcome Dr. Mariam Sharif.
Hello, just 1 second. I'm trying to open the presentation. So, hello everyone. I am Dr. Mariam Sharif from Near East University, Cyprus, and I will speak about the vulva as an immunologically active organ with a focus on the clinical implication at the interface of dermatology and gynecology. This topic is important because it challenges the traditional view of vulvar symptoms as simple irritation or infection, and instead places them with a broader immunologic and hormonal context. This topic matters because vulvar symptoms are common, yet they are still under-discussed in routine gynecologic care. Many patients experience years of delay before receiving a correct diagnosis, especially in conditions like lichen sclerosis. Too often, symptoms are attributed to candidiasis or atrophy without a proper examination, and that delay can significantly affect quality of life. This slide highlights the key point of my talk. Vulvar disease sits at the intersection of immunology, endocrinology, and dermatology. The vulva is not just a skin, and it is not just a reproductive structure. It is a biological, active, mucocutaneous site. When these three disciplines are considered together, the clinical picture becomes more clear. The vulva has a unique anatomy. Unlike keratinized skin, the vestibule and the inner labia contain non-keratinized stratified squamous epithelium, which makes the area more permeable and more sensitive to the environment and to the inflammatory triggers. It has rich blood supply, sensory innervation, and dynamic barrier function that makes it highly responsive but also more vulnerable to inflammation. Here, I want to emphasize the immune architecture of the vulva. It contains Langerhans cells, CD4 plus cells, CD8 T plus cells, all contributing to immune surveillance and barrier defense. Cytokines such as interleukin 1 alpha and interleukin 8 and TNF alpha help regulate healing and inflammation. But when this balance is disturbed, disease develops. Hormones strongly influence vulvar immunity. Across life course, from puberty to pregnancy to menopause, estrogen levels help shape epithelial thickness, vascularity, immune signaling, and tissue resilience. So, when we evaluate vulvar symptoms, we must always ask, what is the hormonal environment doing to this tissue right now? This slide reflects the broader academic basis for this work and the evolving literature on vulvar and perineal dermatosis across the female life course. It supports the idea that vulvar conditions are not just random or isolated. They follow patterns linked to hormonal transitions, immune activation, and patient life stage. Pregnancy creates a unique immune state. Rising estrogen and progesterone shift the immune response towards a more tolerogenic Th2 dominant profile, helping protect the fetus. At the same time, tissue remodeling increases the vascularity and mucosal thickness, which may improve the inflammatory conditions but can also worsen yeast-related symptoms. This image is useful because it visually demonstrates the contrast between hormonally supported tissue and the changes seen after menopause. Menopause is not simply a time of dryness, it is a biologic transition associated with reduced estrogen support, altered barrier function, and increased vulnerability to irritation and inflammation. This comparison makes the hormonal shift easier to understand. In pregnancy, tissue tends to be more robust and tolerogenic, while in menopause, the tissue becomes more fragile and pro-inflammatory. This is why the same symptom might behave different depending on whether the patient is pregnant or postmenopausal. Here we see the three major inflammatory conditions: lichen sclerosis, lichen planus, and psoriasis. These are just not rare curiosities, but they are clinically important diseases that has substantial impact. For example, lichen sclerosis is really important because of its autoimmune nature and its association with squamous cell carcinoma risk, while lichen planus and psoriasis can also be highly morbid and difficult to diagnose. Moving on to the slide, it reflects one of the biggest problems in practice, vulvar disease. It's often normalized, misdiagnosed, or under-examined. Patients may be told symptoms are just part of the pregnancy or aging, or they may be repeatedly treated for fungal infection without confirmatory testing. In many cases, the architecture changes as they are only seen when a proper exam is finally performed. Delay has consequences. In lichen sclerosis, diagnostic delay may extend over several years, and during that time, scarring, sexual dysfunction, and even vulvar squamous cell carcinoma can develop. This is why chronic vulvar itch should never be dismissed casually. It may be a sign of immune-mediated disease that needs timely recognition. This slide focuses on action. Biopsy should be considered when the appearance is atypical, first-line therapy fails, malignancy is suspected, or lesions persist. But diagnosis alone is not enough. Best care comes from multidisciplinary model involving gynecology, dermatology, physiotherapy, and psychosexual medicine. because vulvar disease affects the whole person, not just the skin. There are several important clinical peers here. First, vulvar disease is often immune-mediated rather than infectious. Second, pregnancy and menopause can act as biological turning points. Third, these are chronic conditions that need chronic care, not one-time treatment. And finally, a careful exam of the vulvar architecture is essential to detect subtle but significant disease. In conclusion, reframing vulvar health through an immunologic lens allows for more accurate mechanism-based therapy. This is not just an academic idea, it has direct clinical value. Gynecologists should lean education, recognition, and referral pathways so that the patient receive earlier diagnosis and more specialized care. This slide highlights some of the research that supports and extends this framework. The publications shown here reflect the ongoing effort to integrate clinical observation, immune biology, hormonal transitions, and sociocultural context into a more understanding of the vulvar disease. Looking ahead, the Sharif-Bashkanji framework proposes a mechanism-based stratification of the vulvar disease. Rather than treating all vulvar symptoms the same way, we can group them according to dominant driver, such as estrogen deficiency, hormonal fluctuation, immune dominance, or microbiome influence. This approach makes diagnosis and treatment more precise. And this slide finally summarizes the framework in a practical way. Endocrine status, microbiome ecology, and immune response all interact to shape disease expression. When we look at vulvar disease through all these three axes, we can better understand why some patients develop atrophic irritation, while others develop inflammatory flares or chronic immune-mediated conditions. These references support the scientific foundation of the presentation and shows how this work fits into the broader literature. They can also reinforce an important message. Vulvar disease should be approached through evidence, pattern recognition, multidisciplinary thinking, not through assumptions alone. Thank you very much for your attention. I hope this presentation has encouraged a more thoughtful view of the vulva as an immunologically active organ and highlighted the importance of earlier recognition, better diagnosis, and multidisciplinary care. I welcome your questions and discussions.
Thank you, Dr. Mariam, for your valuable presentation. We truly appreciate your contribution. We will open the floor for questions from the audience, and we also have a question for you. What are the key immune mechanisms in vulvar conditions?
Okay, so 1 second. Can you repeat your question again, please?
Yes. What are the key immune mechanisms in vulvar conditions?
Okay, so the key immune mechanisms involved, they are actually explained clearly in a way that everyone can understand it simply. So the physical barrier, the skin and, sorry, can you see me?
There
Wait,
we go. Now we can see it.
okay. So, wait. So as I'm saying, first of all, the physical barrier, um, the skin and the mucosa of the vulva, they act like a protective wall. They keep the germs out, they maintain the moisture, and they repair well when irritated. When the hormones change, like in pregnancy or menopause, this shield becomes stronger or weaker. Now, not just the physical barrier, talking about the microbiome, as well, because the vulva has friendly bacteria that keep the area balanced, prevent harmful germs from growing, and support a healthy pH. When this balance is disturbed, for example, by using soaps or antibiotics or tight clothes, the irritation and infection can happen. It has also immune cells like Langerhans, T cells, and mast cells. The Langerhans, they detect danger. T cells respond to infection. Mast cells react to irritation and allergies. These cells react really quickly, which is why the vulva become red, itchy, or swollen, even from small triggers. Now, the hormones like estrogen and progesterone, they control how strong or calm the immune system is. For example, in pregnancy, the immune system becomes calmer. That's why we can see fewer autoimmune flares, more yeast, and in the menopause, the estrogen drops. This is why the skin becomes thinner, drier, and more reactive. So, in conclusion, the hormones decide how the vulva responds to irritation, infection, and healing. So, the vulva's immune system works through the protective barrier, the healthy microbiome, the fast acting immune cells, and the hormonal regulation. These systems constantly interact with each other, which is why the vulva is sensitive, reactive, and deeply connected to overall women's health.
Thank you. Does anyone else have any questions? Okay, thank you again, Dr. Mariam. We will be moving on to our next speaker. Our next presenter is Dr. Kudaisi Nawaz, a consultant gynecologist at PAF Hospital, Lahore from Pakistan. The presentation title is K-Rush, Hysterectomy, a pilot study comparison with traditional open abdominal hysterectomy. Now, Dr. Nawaz's presentation is recorded. We will be sharing the screen.
Ladies and gentlemen, Assalamu alaikum. I welcome you all to the conference, and I thank the conference organizers for providing me this opportunity to talk to this elite group of learners. So I'm here to share a little bit of innovation from my side, from Pakistan. Let me share a brief moment that many surgeons in this room might be realizing. We are midway through an open abdominal hysterectomy. The uterus has been mobilized. Your assistant is holding the retractors. And then the operation enters a familiar rhythm. Clamp, cut, ligate. Clamp again, cut again, ligate again. Pedicle after pedicle. Instrument after instrument. And then finally, after all that, we suddenly remember, oh yes, the vault. At that moment, I realized something important. Sometimes in surgery, we follow the tradition so faithfully that we forget to question the efficiency. This led me to a very simple question. Why are we doing so many repetitive steps in this surgery? Because when we step back and observe the traditional workflow of open abdominal hysterectomy, we notice something interesting. The procedure was designed decades ago in an era where surgical efficiency was not analyzed the way we analyze the systems today. Yet today we know something very clearly. Every extra step in surgery means more operative time, more instrument handling, and greater surgeon's fatigue, and potentially more opportunities for error consequent upon that fatigue. And there was another issue that concerned me even more and backed up by literature. Even after all those steps, wall support is not automatically guaranteed in traditional open abdominal hysterectomy. In many cases, suspension of vaginal apex becomes an additional step, sometimes remembered, sometimes forgotten. So the question became, what if we could redesign the traditional workflow of open abdominal hysterectomy in a way that is simpler, faster, and anatomically smarter? That question led to the development of the technique that I will be sharing with you today, the Q-Rush hysterectomy. The idea behind the innovation was very simple. Henry Ford once said, waste of time and motion is the greatest inefficiency in any system. And when you look carefully at the traditional open abdominal hysterectomy, you see a lot of repetitive motion without true value addition. Multiple clamps, repetitive pedicle handling, assistant-dependent steps. But here is the paradox. Even after all that work, the wall support is not always guaranteed. And the chief reason documented in the literature is surgeon's fatigue, leading to forgetfulness in that very last step, consequently ending up as post-hysterectomy ward prolapse in the post-operative period in the longer term. And that question raises a question. If we already have uterosacral and transcervical ligaments, the nature's suspension system, why not integrate them directly into the hysterectomy workflow? Why the wall support has to be an added step? So, the question eventually led to the concept that I'm sharing with you today. So, the technique that I am going to introduce with you today is called Q-Rush, Kutsia's Rapid Unified Suspension Hysterectomy. The idea was extremely simple. Place holding clamps onto both sides to minimize the blood loss, and after that, clamps have no role till your uterosacral ligaments and transcervical ligaments. The Q-Rush implies the rapidness by minimizing the non-value adding steps. Unified means that we are unifying the suspension of wall with securing of transcervical and uterosacral ligaments. So these steps are not separate, but rather they are included in the wall flow here. So we will dissect the bladder from the center of the vesico-uterine pouch and laterally to the round ligaments. And now instead of treating pedicles one by one, we combine the first two pedicles in a single ligature, and surely this saves us 2 minutes on either side as a minimum. Then we ligate and cut the pedicles directly. Placing clamps before cut and ligation, it adds no real-time value. Wall suspension should be an integral part of wall closure and not a separate step. Because in traditional hysterectomy, we all know that wall closure is done as a separate step and then we suspend the wall with the ligaments. So Q-Rush integrates the wall suspension and closure into one continuous maneuver. So there is one suture, one suspension, and one streamlined workflow. There you can see that I have applied the clamps, the holding clamps on the upper part of the uterus, and these will be handed over to our assistant. After that, clamps will have no real role till we reach the transcervical pedicles. Here the lines in blue, they show where we are going to ligate. And in case of we are securing the ovaries, thread will be ligated and placed securely medial to the ovaries. But if we are going to remove the ovaries, it is going to be placed lateral to the infundibulopelvic ligament, and we will pass the suture such that the entire round ligament and the TO complex, it is taken along with the suture. After that, we will ligate the uterine arteries on both sides, and after that, we will place the holding clamp to securely hold our transcervical pedicles on both sides. And here I recommend using the clamp in reversed fashion so that the vertical part of the clamp is placed just perpendicular to the transcervical ligaments on both sides. So this is the front and back review. Here, this is the topmost view of how the holding clamps are used and where the ligature is placed directly without using a clamp. Now here you can see on the left side how the vaginal cuff looks like when we transact and remove the uterus through clamping, cutting, and ligating the pedicles chunk by chunk in piece by piece small manner. But after we have secured the transcervical ligaments on both sides to the wall, the appearance is that on the right-sided picture. So this is the real life image taken before suspending the vault to the transcervical and uterosacral ligaments. The image on left depicts that image, and image on right shows the final appearance of what the vault would look like if it is closed through a Curesh technique. And the same look can be achieved by suspending the vault closure after closing the vault in the traditional abdominal hysterectomy, but that is a separate step. Here we achieve the same result in a single suspension suture so that vault is both supported and suspended in one simple maneuver. I would also like to mention here that the entire study that I'll be sharing with you is the pilot study, and the number of patients is small, and it is a single center study since I'm no more working in that center. So I would like to collaborate with my audience to conduct larger scale studies in whatever centers the open traditional abdominal hysterectomy is still being done, which I believe is the case in most of the underdeveloped as well as developing countries. So this is the link to procedural video.
Today's video demonstration is about clampless hysterectomy. Normally, we clamp and then ligate and cut the pedicles while performing hysterectomy. However, this modified technique removes the need to place a clamp. Instead, we just continue to ligate and cut our sutures, thereby removing one step of clamping the pedicles enhances the speed of surgery, and we are able to complete the surgery more faster way and in a secure way as well. Here you can see at certain points we use backside of the needle to enter a pedicle. The backside of the needle being non-pointy and not sharp allows us to slip past a vessel without puncturing it, and thereby it works the same way as an OSHA clamp to help us ligate a pedicle without puncturing its vessels. Here you can see that we are cutting the ovarian and the round ligament pedicles together, and we have ligated them after we had secured the set pedicle at both the ends. We are securing both the ends of the tubovarian pedicle as well as the round ligament. Now we are moving Now we are dividing the peritoneum of the vesicouterine pouch to push down the bladder. The use of cautery promotes a bloodless surgical field. Here the clamps are being used only to prevent the backflow of blood from cut ends, which can make the operative field difficult. Also, holding the uterus with these clamps can help us in stabilizing the position of the organs that we are trying to remove in the operative field. Now we have passed the needle in a reverse fashion after feeling the uterine artery to tie it at one end, and now we are passing another ligature to obliterate the uterine artery 1 centimeter below the first one. We have used OSHA clamp just besides the cervix after feeling the cervix to obliterate the vessels. The ligature will be passed medial to the vessel and knots will be tied lateral to it after securing the vessel through the tissue so that the chances of slip ligature can be minimized. We have to make very good and tight knots which will not only obliterate the blood flow but also minimize the risk of ligature slipping. Now we are feeling the uterine vessels on the other side, and we have utilized OSHA clamp to ligate the vessels of the other side. After we have ligated both the vessels at a distance of 1 centimeter on 2 points on each side, we will cut the vessel so that the pedicle becomes free. We are pushing the bladder further down. Any adherent remaining fibers of the bladder are being divided by cautery, and it is being pushed down so that the bladder fibers are not taken as we move down to remove the uterus. We have to ensure the sanctity of each individual organ while performing surgery to be safe surgeons. After dividing and cutting both the uterine arteries, now in the last, we have to take up the transcervical ligament. This pedicle we will hold with the clamps by applying the clamps in reverse fashion so that the tip of the clamp is just parallel and alongside the cervix to match the natural anatomy. You see many surgeons apply the clamp the other way around with curvature of the clamp medial. However, we recommend and apply the clamps such that the curvature allows us to fit the clamps just parallel to the cervix and not the other way around. After we have applied clamps on both sides, we will now feel the free vagina, where the vaginal vault is gliding and sliding freely above the cervix while cervix is still attached. And after we have identified that, both on anterior and posterior aspects, we will open the vaginal vault with the help of a cautery. Posteriorly, the vault is opened between the two uterosacral ligaments. Afterwards, we divide the cervix just medial to our clamps to open the vault. So here you can see that we have opened the vault while holding the transcervical ligaments still with the clamps, but we did not open the vault chunk by chunk as many surgeons do in the traditional method. The vault has been opened and the transcervical ligaments and vault all will be taken in one suture. This has two advantages. Number one is in terms of time benefit that we gain with this surgical technique. And the other benefit is that the transcervical ligament stays attached to the vault when we ligate it with our method with the same suture which is being used to close the vault as well as to ligate the transcervical pedicles. This in turn can reduce the risk of post-operative vaginal vault prolapse, which we've seen in many of the traditionally performed surgical cases. As you can see, after ligating the transcervical pedicle, we are tying it to the vaginal vault. Now we are securing the vaginal vault by closing it and securing our hemostasis. We hope that you have enjoyed seeing this video and it proves to be a learning video for all our trainees and the audience. We hope to continue contributing to the specialty by bringing in more innovative ideas. Thank you so much for being with us.
And you can take a picture and maybe access it later on. So this is the literature comparison of QRUSH versus the traditional abdominal hysterectomy. You can see that mean operative time is, we gain an advantage of almost 10 to 14 minutes in the QRUSH technique, and average time saving being 12 to 16 minutes. Estimated blood loss in both the techniques is almost equal. It's not statistically significant. And the number of bladder injuries or VVF that we had was none in both cases. And mean hospital stay was almost similar in both cases. And however, vault prolapse was reported within 1 year in traditional abdominal hysterectomy approach, and it was nil in QRUSH approach. And mind you that the traditional abdominal hysterectomy data was collected retrospectively and was done by a different operator. By that, I do not mean that I want to blame any operator. I just want to make my point that in traditional technique, it is very likely that even a skilled surgeon can forget suspending the vault as a separate step to vault closure, especially if it is a difficult surgery. We do not have correlation to that in this study. One interesting thing about surgical innovation is that it really begins with a grand plan. It usually begins with small irritation, a step that feels unnecessary, non-value adding, a maneuver that feels insignificant. And when you start asking, can this be done in a simpler or a better way? Sometimes the answer becomes a new technique. So that is the case with the QRUSH hysterectomy. So innovation in surgery is often imagined as robotics, artificial intelligence, or advanced technology. But sometimes innovation is much simpler. Sometimes it's just looking at a familiar operation with fresh eyes. QRUSH is an attempt to make open hysterectomy faster, simpler, and anatomically smarter. And if it reduces the operative time, improves apical support, and makes surgery easier for the next generation of surgeon, and if this technique shortens the operative time, I'm sure that our spines and our physiotherapists will both be extremely grateful. The surgeon who improves a procedure improves lives of thousands of patients we will never meet. Thank you so much for listening.
Okay, we want to thank Dr. Nawaz for her presentation. Now we're going to move on to our next presenter, which is Dr. Anam Yahya, who is a pediatric trainee in the United Kingdom. From the United Kingdom, presenting on silent inflammation, lasting impact, coronary artery aneurysms in 3 cases of atypical Kawasaki disease. Please welcome Dr. Anam Yahya.
Thank you so much, Zanab. Hello, everyone. I'm Anam. I will be presenting, like how Zainab has already mentioned, the 3 atypical cases of Kawasaki disease. I'm a pediatric resident, currently training in NHS England in my 2nd year of residency. I'm just going to share my slide now. Sorry. Are you able to see my screen?
Yes.
Okay, perfect. So these are the 3 cases which were very peculiar in themselves and presented to us on a normal ward basis at different occasions. So we have done a retrospective study on these 3 atypical cases of Kawasaki disease. I'll proceed through in a chronological order, one by one, and we'll talk about the cases then. So all these 3 cases, different age groups, 7 months, 9 years, and 13 years, diagnosed with atypical Kawasaki disease, presenting with coronary artery aneurysms. It just highlights the diagnostic challenges and the importance of early recognition in all these 3 cases. Now, case 1 was a 7-month-old infant who presented with 2-day history of fever and 1-day history of vomiting, generally unwell on admission. So initially, we treated the child with antibiotics, screened for suspected sepsis, taken the regular blood cultures, and also did an LP. But throughout the stay, we noticed that at around 12 days, the fever did not settle down. It was still persistent fever despite antibiotic therapy given. Now, before what happened during the 12 days, we did a series of investigations. But this is what developed around day 12. That is bilateral non-purulent conjunctivitis, maculopapular rash, and there was erythema of the hands. Mind you, this was not the presentation on day 1 of illness. During the 10 days of illness, we did a series of investigations like the blood cultures, which were negative. We did lumbar punctures, which was initially positive, but that could be contaminant. So we repeated it again, which was negative. We did viral PCRs, urine culture, throat swab, viral screen, everything was negative. The ECG and the abdominal scan were normal. There was one thing which was elevated throughout was the raised inflammatory markers, that is the CRP. The highest was 154. There was raised white cell count as well, which went up to 30. Platelets were initially normal and then rose as well. BNP, which is a silent indicator of Kawasaki disease, was noted to be elevated later on as well. And there was also deranged liver function test during admission. So the reason why we started suspecting Kawasaki disease was the child was on IV antibiotics for the first 10 days, but then there was no improvement in the clinical picture. And that's when the child also developed these symptoms of atypical Kawasaki disease. At that point of time, we had a rheumatological consultation with our tertiary care hospital, where atypical Kawasaki disease was diagnosed based on the clinical criteria. and the inflammatory marker profile. At that point of time, we also had an acute echo done on day 13 of illness, which showed coronary artery aneurysms. I will talk through the scoring later on in the slides, but just for now, there was a right coronary artery measuring 4 to 4.5 and LCA of 4 to 5. CT angio was done few weeks later down the line during follow-up, which also showed stable aneurysms, and there was no thrombus during that time noted. Now, this is just a picture of echo of LCA and RCA. Treatment-wise, like I said, we first suspected sepsis, so we went down the septic pathway, treated the child with IV KEF, switched to IV meropenem after microbiology advice, and once we had diagnosed Kawasaki, we started with IVIG, IV methylpred for 5 days, and then high-dose aspirin, which was later transitioned to low-dose aspirin. We also gave anticoagulation because of the medium to large size aneurysms, which we started off with warfarin and then bridging enoxaparin, targeting INR of 2 to 3 at that point of time. Once the patient was clinically well with no fever, eating and drinking normal, looking bright, we then started following up with the discharge planning meeting. We noticed that as soon as we gave the IVIG and the steroids, the temperature settled on its own and there was normalization of CRP as well. Regular cardiology follow-up has been arranged for this patient. Continued anticoagulation with warfarin and plans to remain INR between 2 and 3 has been decided. Follow-up imaging, like I showed, the CT angio also showed stable aneurysm. Aspirin is now on low dose maintenance, and there has been future follow-up planned at the local hospital and the specialist cardiology unit with repeat imaging and monitoring scheduled. Now we move on to case 2. This case is basically a 9-year-old child who was initially treated by scarlet fever by GP. Now, this was around 2 weeks before the presentation. The child presented 10 days later with fever, persistent fever throughout these days after getting treated by scarlet fever, did not improve, fever for more than 5 days. There was vomiting, diarrhea, cervical lymphadenopathy. The patient was very hypotensive, initially managed with IV fluids. We screened the patient immediately with broad spectrum antibiotics. And because of the clinical picture of fever for more than 5 days and cervical lymphadenopathy and clinically unwell, we suspected atypical Kawasaki disease at that point of time. Initial investigation showed RAID CRP, ESR was elevated, and elevated BNP as well. We also did a septic screen, cultures were negative. We then consulted with rheumatology again, and suspected KD was diagnosed. At that point of time was suspected. So we treated the child with IVIG for 3 days and IV methylpred for another 3 days. Fever resolved post IVIG, and the echo during acute phase showed coronary artery and enlargement as well. I'll mention the Z scores in the next slide. CT angio, which was done in follow-up, also showed stable aneurysms during that time with no thrombus formation. This is the echo imaging finding, the acute echo done during the illness, but it was only after day 10 of illness, day 10 to day 13 of illness. In terms of management, we started the child with warfarin and aspirin. There was some hair loss noted on warfarin, so we had to switch temporarily to Clexane after consultation with pharmacists and then resume back to warfarin. Regular echo and CT angio were planned for follow-up, and continued anticoagulation was needed to support in order to prevent clot formation. And we also advised to avoid contact sports during this time to avoid bleeding risk. Case 3 is basically a 13-year-old child who presented with 1 week history of right-sided neck swelling and fever associated with odynophagia for 1 day and generalized weakness. On physical examination, he was febrile, had a firm erythematous, fixed cervical swelling on the right side, measuring around 3 to 6 to 10 centimeter. It was hot to touch, and FNE done then demonstrated right parapharyngeal swelling as well. At that point of time, we had an ENT review done as well, who then suggested for CT neck, which we had done at that point of time, which showed matted lymphadenopathy without abscess formation or mediastinal extension. So initial investigation showed raised CRP, deranged liver function test, CMV and EBV at that point of time was pending, which was later negative. White cell count was raised. There was also abnormal prothrombin time, and the child required multiple doses of vitamin K as well. The initial management include IV ceftriaxone and IV metronidazole based on the suspicion of bacterial lymphadenitis, and a 3-day course of DEX, which did lead to partial reduction of the neck swelling, but the fever did not come down and the child was still clinically unwell. So the child represented during that time. And when the child represented, there was recurrent fever, conjunctivitis, and blanching erythematous rash, prompting again consideration of atypical Kawasaki disease. A rheumatological consultation again was supported this diagnosis, and the patient was then again given 2 rounds of IV immunoglobulins, 3 days of IV methylpred, which was later transitioned to oral pred over a 16-day period. Echo done during the acute phase also showed medium coronary artery aneurysms with RCA measuring 6, Z-score of 4, and LCA Z-score of 5. A CT angio was, as we speak, the CT angio will be getting done now. It's planned at the hospital as an outpatient, but there was no ECG changes during the acute admission phase. During this course, the child also had a neurological event, which basically the child developed a left-sided lower motor neuron facial nerve palsy, which resolved on its own. But during this time, we also did some MRI brain and MR venography imaging, and which were all normal at that point of time. Treatment in this case was aspirin along with another dual antiplatelet therapy, clopidogrel, omeprazole, oral prednisolone on the weaning regime, and vitamin K, which was given during deranged prothrombin time. In terms of outcome and follow-up, we discharged only when the patient was afebrile, clinically well, and tolerating oral intake, and all these positive indicators happened right after giving IVIG. We continued on dual antiplatelet therapy under GP supervision. CT angio is yet to happen, and the outpatient cardiology is yet to happen. There has also been subsequent review and imaging planned at 2, 4, 6, 8 weeks in terms of follow-up at the local hospital. And there's also a tertiary hospital follow-up for in terms of rheumatological aspect planned. Now, there's something to highlight. In all these 3 cases, what I would like to talk about is we had difficulty to diagnose these 3 cases. As you can see from my presentation, so far all 3 of them were treated with something different to Kawasaki disease. The first one was treated for suspected sepsis. The second one was treated for scarlet fever initially, and then later only diagnosed with atypical KD. And the third one was treated for bacterial lymphadenitis initially. So Kawasaki disease was only thought when the timeline went by and the child remained clinically unwell and the fever was persisting. And certain features of Kawasaki disease only then started to appear, like the conjunctivitis, the rash, the skin peeling, and the echo in acute phase showed coronary aneurysms. And all of them, as soon as they were given IVIG, showed immediate improvement and got better. So one thing to note is they all received IVIG only more than 10 days after their illness. All of them had acute echo. In that, we could already see the coronary artery aneurysms. Just a discussion regarding Kawasaki disease. As we know, it's the acute vasculitis of childhood, which can lead to coronary artery aneurysms, atypical or incomplete Kawasaki disease. It often presents as a diagnostic dilemma among clinicians, particularly in older children, because it's more likely to happen in less than 5 years old. All these three cases, case one, suspected sepsis, post-viral symptoms, cervical lymphadenitis, they mimic different pictures, and therefore there was a delayed recognition which further increased the risk of coronary artery aneurysms. Incomplete or atypical Kawasaki disease mostly occurs in infants who are at substantial risk of developing coronary artery abnormalities, who have prolonged fever as the sole clinical indicator, or have subtle or fleeting clinical signs in addition to fever. The diagnosis is incomplete and should be considered in any infant with prolonged fever. So, as we know, the clinical features of or the criteria of typical Kawasaki disease is fever for more than 5 days plus 4 of the 5 clinical criteria, which is maculopapular rash, bilateral non-purulent conjunctivitis, strawberry tongue, peeling of the hands and fingers, and erythema, palmar erythema, and then cervical lymphadenitis. And of course, echo findings which show coronary artery aneurysms. But we often do not get this whole picture of uh, mm, all the clinical criteria meeting and for treatment to start. And that's when the delay arises, and that's when the dilemma arises. So what I'm trying to say is Kawasaki disease should always be in mind whenever we suspect children with prolonged fever without any source of infection. This is basically the coronary classification based on how they have classified the aneurysms, the Z score, and the small, medium, and giant aneurysms. This is based on 2020 Japanese Circulation Society guidelines, in which they have classified it as Z score of 2 to 5, which signifies small, and 5 to 10 is medium, and giant is more than 10. Similarly, if you don't have Z score available, which is based on the body surface area, you can also do the absolute diameter, that is small, medium, and giant, which is 3 to 4, 4 to 8, and giant is more than 8. There's also an AHA classification, which more or less is similar to the JCS classification of small, medium, and giant aneurysms. So in our case series, we have, depending upon these classifications, we then see there is medium to giant aneurysms in case 1. That is, we have given long-term anticoagulation for this case. In case 2, there is a giant category of aneurysms, which reflects a lifelong antithrombotic therapy and close imaging surveillance as well. In case 3, there is medium aneurysm, and we have started on dual antiplatelet therapy. So basically, I went through a lot of research, a lot of studies have been done regarding how to treat Kawasaki disease more promptly without any delaying in treatment, because the delay in treatment increases the risk of coronary artery aneurysms. And there has been a lot of case series, a lot of publications done, and the lessons learned from them is we should always suspect KD in patients with prolonged fever and elevated inflammatory markers, even in the absence of full clinical criteria. Timely IVIG therapy, that is within 7 to 10 days, can delay the risk of aneurysm formation. Having said that, there has been cases where even after timely IVIG intervention, patients have still gone and developed coronary artery aneurysms. For refractory or late presenting KD, corticosteroids have shown benefit in reducing CAA incidence, and that's why we have always given prednisolone in all our 3 cases. Routine echo at 2, 4, and 8 weeks after the diagnosis, and advanced imaging such as CT angio or cardiac MRI is needed whenever and should be done. Long-term management requires individualized antiplatelet or anticoagulation therapy based on aneurysm size and Z-score risk. In terms of the routine echo, I also want to highlight one thing. when we do echo findings may only be reflective at around 2 weeks of the presentation. If we do echo before and it comes as normal, that does not rule out Kawasaki disease at that point of time as well. And in cases of prolonged diagnosis of in cases of prolonged prognosis and surveillance, small aneurysm regress in 99% of the cases, medium in 50 to 90, and giant rarely regress. There's high risk of stenosis, thrombosis, and myocardial infarction. We have a giant aneurysm in our case too. And in case of our management, it did align with the AHA guidance of small, medium, and giant, where we did low dose aspirin, routine echo. In medium, we did aspirin, clopidogrel, and imaging. And giant is warfarin and aspirin, bridging with enoxaparin. Each patient in our case series underwent IVIG and corticosteroid therapy with escalation to anticoagulation as needed. Importantly, early echo screening, Z-score based classification, and multidisciplinary input, including cardiology, rheumatology, and hematology, were key to optimizing outcomes. Like I said, this basically reinforces the fact that we have to be more vigilant and more prompt in diagnosing atypical Kawasaki disease. But there's also something I want to leave it to the forum for discussion, and maybe just a thought in your head. Kawasaki disease is basically a systemic vasculitis. It's not a coronary artery disease. We routinely look at the coronary arteries because they determine how much of the morbidity and mortality a case can hold. But if we solely focus on the coronary arteries, are we like potentially missing the vascular involvement elsewhere? As our understanding of Kawasaki grows further day by day in terms of prompt intervention, early recognition, and early diagnosis, we should also think about the role of broader vascular imaging in selected high-risk patients, which remains an important area of discussion for future research and debate as well. Thank you so much for your time, and thank you for having me here today. Any questions for me?
Thank you for your presentation. It was excellent and very informative. We're going to open the floor for questions.
Okay.
I'm going to ask you a question. How does silent inflammation affect coronary arteries?
So there is basically a lot of factors which would affect the coronary arteries. When I say silent inflammation, it could be the arteries having inflamed on their own because of the body fighting against it. I'm not too sure how it relates to the coronary arteries in terms of the thrombus formation or the clot formation, but that could be because the body, because of the inflammatory markers which are present and which rise during this time, there could be a chance of thrombus and clot formation because the body is not able to fight on its own, if that makes sense.
Any other questions for Dr. Anam? Okay, so we are going to take a short coffee break, okay? And then we'll get back to the presentations.
Okay. Thank you so much. Thank you.
You're welcome. Thank you. Okay, welcome back. It's now time to introduce our next speaker, Dr. Michelle Shah, a pediatric lifestyle medicine specialist from India. Her presentation title is Preconception as a Pediatric Health Intervention. Please help welcome Dr. Michelle Shah.
Hello, everyone. A very, very good morning. I'm just going to share my screen. Give me a second, please. Perfect. I hope my presentation is visible to everybody. The whole idea of this conversation around preconception as a pediatric health intervention comes from the sciences of epigenetics and the science of the developmental origins of health and disease. I'm a pediatrician by training, and we often focus on everything that happens in the child's life after they're born, from minute one of them being born. But what if we flip the script a little bit and thought about how the preconception period could be one where we could intervene to help the child gain the best possible health? Um, as I go through this presentation, there will be a couple of points where I will speak a little bit about the research that's been done around this. But as I was highlighting, the two most important pieces of research that we're taking into consideration here is the field of epigenetics, which essentially tells us that we have our genes, half of them come from our mom, half come from our dad, but there is an influence of lifestyle on genetic expression. It doesn't change the genes that we have, but it does change how they're expressed. Think of epigenetics like a piano. The keys of that piano are set. But if I were to play it and I don't know how to, it would sound like noise to you. You would be like, please make her stop playing this. But at the same time, if someone who was good and who was a good piano player would be playing this, then you would be like, okay, this is music. So that's exactly what the field of epigenetics is. It's how the lifestyle of the parents influences the genetic expression in the baby. By the time a child reaches my clinic, the most important chapters of their life are already written. And this is something that I've seen happening time and time again because there is only so much health intervention that is done in the preconception period. And especially for our generation, with the rates of IVF and fertility treatments going higher and higher, we don't really focus too much on optimizing the health of the couple before they think about conceiving the baby. What we think about is focusing and optimizing their protocols, whether they need to do an IUI, an IVF, or an ICSI, whatever the procedure might be. However, certain parameters, certain metabolic end goals are already written for this child before they're even born. So, like for example, this kind of depiction is of the developmental origins of disease, which says that what happens in the womb is sets the tone for a lifetime. What I would contradict and say is what happens before the baby's even in the womb is what sets the tone for the baby's lifestyle. So there are a couple of really amazing pieces of research that have been done, which have been adding to our own knowledge of the field of epigenetics and the field of preconception. This is one which I found which was pretty interesting. It's from Botland and Jittle, done in the year 2003, and they studied agouti mice. Now, agouti mice are these yellow obese mice, and they look that way because of this agouti gene in their DNA. What they found is when they had a control group which got a standard diet, there was no change. They definitely had their their kids or the lineage that followed had this agouti gene switched on. So these mice also appeared yellow and obese. However, at the same time, they took a set of mice and controlled their diet. So these diets that you see are indicating a high micronutrient rich diet. And what they found surprisingly was that in these mice who got this fortified high micronutrient diet, the agouti gene was actually switched off. And these mice looked like regular mice, which were kind of more leaner and they had a darker skin tone. So, this is one of the first or one of the biggest indicators of how diet directly influences the process of reproduction and the end goal of reproduction, which is having a healthy baby. In so many of our cases as well, we would have seen this that, for example, using the field of evolutionary medicine, if you think about how a typical Indian woman stores their fat, we do store our fat a little bit more around the hips as compared to a Caucasian woman. We find it harder to put on muscle as compared to a Caucasian woman. Now, the reason for this could be based in evolution. That as a continent, we had to see, as a country, we saw a lot of famine, a lot of droughts. There were periods of uncertainty for our own bodies to understand where we're going to get our next meal from, which could be why, over a period of time, our body has used evolution and has learned to take that food and use it in a different manner, similarly to what the agouti mice did. What does that mean for our preconception patients, though? That a huge part of preconception comes down to hormone management. And for a lot of our PCOS patients, PMOS patients, rather, I should say, we do tell them to lose weight, we tell them to get fitter because weight management is going to help their PMOS regulate. I would say, though, that please also add a point that there should be no crash diets done for that patient at all, because we do not want their body to go in a state of fight or flight. We don't want their cortisol to rise up, and we definitely do not want a signal on an epigenetic level that you need to be in a mode where you have to store fat, because that is then signaling to the baby that you need to store fat, and this is the starting point for many metabolic conditions that we see later on in life. What we also know about the field of epigenetics and the developmental origins of disease is that there is a transgenerational inheritance to it. When I say transgenerational, I mean that what has happened to our grandparents sometimes even shows its effects in their grandchildren, maybe even a couple of generations down below. Another really amazing study which was done on mice again, where every time they were made to smell this cherry blossom scent, they used to get a little bit of a shock. So over a period of time, they started realizing that every time I smell this, I'm going to get a shock. So they started fearing the smell of cherry blossoms. When an MRI was done for these mice, they found a structural change in the brain. The brain literally changed to accommodate this fear. What's surprising is that in their children and in their grandchildren, this same fear existed even though they had never smelled cherry blossom scent ever before. And the same brain changes were also seen, which tells us the power of transgenerational inheritance of epigenetics. Currently, when we talk about longevity, we want to have longer lives, we want to have we want to have healthier lives. I would say it all starts before. It starts before we're even born, which is why we have to put in the work there. So, what I tell all of my patients is the 90 to 120 days before conception are the golden period of time, because we know that the sperm's life cycle is about 72 days. So, it is going to regenerate every 72 days. Now, when I say 90 to 120, this is the most, like, it's the shortest window of time. Anything above and beyond this is definitely amazing. For the egg as well, the egg takes 120 days to mature. So the egg which is released in our current cycle took 3 months to mature. So this 90 to 120 day period is golden for any couple on their preconception journey to help them optimize their lifestyle and then try for conception or then think about conception. Half of a child's blueprint comes from the father who has never been counseled. Now, unfortunately, the entire process of trying to conceive a baby, the onus gets put on the mother inevitably. It's her body, her blood tests, her eggs. She has to go through the entire process of IVF and stimulations, etc. But what about the dad? The dad and the father has usually never been counseled about how his lifestyle influences the health of the baby. There's a study which has been done which says that when fathers have exercised and done strength training specifically 3 months before conception, it's actually reduced the risk of obesity in their future generations, which is a huge statistic for us to say that, because when we think about longevity, when we think about expanding our lifestyle and our lifespan, we have to be very certain that the father is also involved in this process equally as the mother. What I counsel my patients is that in the preconception period, it's the both of you. In pregnancy, it comes down to the baby. and the mother. And then when the baby is born, our focus just goes on the baby. So as pediatricians, we're taking a funnel down approach, but the top of the funnel is the parents. It's both of them and not just one. So when you have a couple coming into your clinic now, I would request that you ask them this question instead of, can we achieve a pregnancy, which is what most couples come with. What we rather want them to ask us is, what is the healthiest possible child this pregnancy can create? And that's what we want. That's going to be our end goal. So think of this entire process of preconception as a pediatric health intervention like putting fertilizer into a soil. The soil exists, the plants exist. But a plant is going to grow very differently if the soil is sandy, it doesn't have fertilizers, it doesn't have vermicompost in it, it doesn't have all of these amazing things. Whereas a plant which is going to grow in a very, very fertilizer rich soil, which has a lot of micronutrients and minerals, etc., is going to grow very differently. We want couples to focus on the latter. We want them to take some time to prepare their soil before they think about planting a seed. And that's what the entire work around preconception comes down to. That how can we get the couple to their most healthiest, their most optimum selves before they think about conceiving a baby. And here I also want to add one more point that when I talk about preconception work, I'm really focusing on three major things. There's definitely the body, but there's also the mind which needs to get ready, which is equally important. And secondly, and thirdly, and I think this is a very, very important aspect of preconception work, which we often forget, is getting the parents ready to becoming parents. I can only say so from my own personal experience in India that a lot of time couples have babies not because they really, really think that they should, but because there is a huge amount of societal expectation also that you need to have a child. And oftentimes the couple themselves are actually not ready to becoming parents. Parenting is one of the hardest jobs anybody ever does, but no exam is taken before the child is handed over to them and sent back home. So, in the preconception period, I think it's also a lot about getting the couples ready emotionally to have a baby, to have those hard conversations. I ask a lot of my own patients to think a little bit more about their own life, their own childhood, what they liked about it, what they don't want to take back from it, what they found which was very, very helpful for them. Because all of that is going to be how they conduct themselves as they become parents as well. So, this is what the whole idea of preconception as a pediatric health intervention is that when we think about having healthy kids, when we want our kids to live long and live better lives, live a life free from chronic diseases, which is a lot of the work that I do as a pediatric lifestyle medicine specialist, we can't just start it when the child is in front of us. The work has to be put in before because that's going to influence the child's physical health, mental health, and emotional health.
Thank you so much for your wonderful presentation. We sincerely appreciate your efforts and insights. And I do have a question for you. How can early interventions improve long-term child health?
Absolutely. So, again, various studies have been done. This is a very well researched subject of the field of epigenetics, wherein essentially what a couple of these studies have found is better glucose control earlier in preconception, so before the child is born in the parents, leads to a child who has a lower risk of metabolic conditions later on in life. The second one is actually a lot related to the dad. So the father's ability or the father's inclusion of strength training into his day-to-day activities before he goes into conception actually again influences the child's risk of metabolic conditions and obesity specifically. Thirdly, I think we all know the impact of cortisol on the baby. We know the impact of a lower amount of cortisol and how that improves the baby's mental health for the rest of their life, which is where improving the parents' mental health comes in. That when their mental and emotional health is a lot better and the mother's feeling a bit more supported, it's definitely going to lower the risk of cortisol exposure for the baby, thereby giving the baby a more resilient future, essentially. So, this is, I think, it's a trifold approach wherein it takes into account physical health, emotional health, and mental health. But these have all come together to show us that there's definitely a lot of improvement that the baby also receives.
Right. Thank you so much. And I think what you're saying is definitely very important, especially with the societal expectations and how sometimes, parenting is a very hard job and, not knowing those expectations before. So I think it's very important, and I do agree. It's kind of like a domino effect.
Absolutely. I mean, I cannot tell you the number of times that I've seen patients who come to me in the preconception period who are literally just having a baby because they think that they need to. And again, I know that you're never really ready for a baby. I know that you sometimes have to jump in line. But what I do ask patients to do at that time is really just take a check about their own well being, their own emotional health before they jump into becoming parents and spend even a couple of months, even just 3 months, to really reflect back on what they want to pass on. Because once the mom becomes pregnant, the attention just completely switches to her health, to the baby's health. Is the baby putting on weight? And then, of course, once the baby is out, there is no putting in all of this work, there is no time for it. The parents just become really preoccupied. So it's that preconception window where the parents still have some time for their own selves to put in this work before they think about having a baby.
Thank you so much. We really appreciate your efforts. Now we are going to move on to the next speaker. Our next speaker is Mr. Christian Alda Sianapiar. I hope I am pronouncing it correctly, from the Department of Obstetrics and Gynecology from Indonesia. He will deliver a presentation on concordance and acceptability of HPV DNA genotyping test by patient self-sampling compared to clinician sampling. Let's warmly welcome Mr. Christian.
Yes, thank you very much for the warm introduction. Hello, everyone. I'm Christian, and it's my honor for me to present at today. So I will present first my presentation. Can I share a screen for now? Sorry. Okay, so here's my presentation. So my research comes from the question: is it really possible for a woman to collect their own HPV sample for the HPV testing? And I think it's nowadays the self-sampling of the HPV sample, it's already emerging as a new uh, alternative for us to increase the HPV test. So it comes to us a question for this research, and we will try to answer by using this research, especially in our nation in Indonesia. So our research title is a comparison of self-collected and physician sampling with the woman with the HPV genotyping positive in our center. It's in Indonesia. It's especially in Ciptomangun, Kusumo. It's an our general hospital in the National Referral Center in our nation. So we know that nowadays the cervical cancer is still the second most common cancer, especially in Indonesia. It's among women in Indonesia. It's remain major cause of the cancer-related morbidity and also the mortality. So it's in Indonesia, it's more than double compared to the 2008, and from the global count 2022, we know that the new case is still 36,000, and the deaths from the cervical cancer it's 20,000. So without an effective prevention, screening, and a treatment strategy, cervical cancer is projected to cause more than 1.7 million deaths among Indonesian women by the 2070. So we try to find another way out from this thing. So scalable and effective screening is one of the key to saving on the life and reducing the burden of the cervical cancer in Indonesia. We have We hope by increasing the detection will give us a fewer costs and more life-saving. So being
Mr. Christian, I'm sorry to interrupt, but can you please speak a little louder?
okay, I'm sorry. Is it
Okay.
already uh quite louder here? Can you hear my
Yes,
voice?
that's a little better.
Okay, thank you. So, despite for permission to continue our presentation. So, despite being a preventable disease, cervical cancer screening coverage is still remains low in Indonesia. If you can see, by the 2017 until the 2023, the number is still 14.6%. It's really high gap with our target in the 70%. And now, and from the nation, from the national health in Indonesia, our new target is 75%. So we have a really high gap. It's still 60%, and we still waiting for the new data by the 2026. And so we know that some of the barrier of this screening was the fear of the examination of procedure, the social stigma, the lack of family support, and then the limited access to the healthcare services. So we tried to design this research, it is a study design with the diagnostic, and it's we did it in the colposcopy clinic. We have a special colposcopy clinic in our center. It's with the sample is women with abnormal pap smears result, because we need to have a better coverage of the HPV. So we just have the abnormal pap smear result for the sample. We have 48 patients here. So this is the study workflow. Yes, sorry. The patient that already have the consent will have the baseline assessment, and then we will educate them by using the self-sampling education, like in the right of the screen. There's an instructional video with the sampling demonstration, and then we will ask the patient to did the collected vaginal swab, and then we also sampling it by the physician, and then after that we send it to the laboratorium to did the genotyping, and we will continue with colposcopy if it's indicated, or we will have a lip or LETs for abnormal finding in the colposcopy. So by the characteristic, we know that it's still 41% of our patient is come from the 30 until 40 years old. So I think it's represent the primary target population for the cervical cancer screening, and the most of them is multi-parity. It's 68%. We know that the repeated pregnancy will induce the cervical psychological changes and may increase the susceptibility of the HPV-related carcinogenesis. And then the education is most of our women that already have screening, because we our target is the patient with a positive finding in cytology. So most of our patient is high graduate patient, because I think with the higher education, it's they tend to get the screening more often. And then another risk factor that we find in this study is the hormonal contraceptive tube, and then half of our patient it's a multiple sexual partner. So by the sample, we have a 48 sample by the physician. From the 48 sample, we have a 33 positive with 68% positive finding, and then by the patient sampling, it's still 28 or 58. And then we try to analyze this with the Cohen kappa. We have 0.778, which is a good agreement with the p-value. It's 0.0. So we conclude that it's selective collector sampling show a good agreement with the physician collector sampling of HPV DNA, and most of HPV DNA is 16 as the most prevalent genotyping. It follow with the 18 and 52. It's everything is the high risk HPV. And then we ask the patient to answer some question to from the questionnaire to find out is it acceptable by the patient or not. So our patient is 100% of our patient is think it's easy to do this examination, and 60% is prefer to have it as self-sampling. So I think it's a really good acceptance by the patient, and it will increase our coverage. And 100 patient, it's really recommend to interested to recommend this self-sampling to the others. So by the conclusion from of our research, we know that HPV self-sampling is a really good agreement with the current kappa is 0.70x16, and it's highly acceptable by the patient. With 100 patient have a form of sampling, it's easy to perform, and 95% is willing to undergo routine HPV DNA screening, and 100 sampling to the other. So the home message is this: the HPV DNA self-sampling is a really feasible and highly acceptable, and this screening strategy that could help us, the Indonesia, to increase the cervical cancer screening uptake in Indonesia. I think it's all about my presentation about our research. Thank you. Is there any question that I might answer for this research?
Thank you, Mr. Christian, for your valuable contribution. We do have a question. What is HPV DNA genotype testing?
Pardon me. Can you repeat the question?
Yes. What is HPV DNA genotype testing? Can you talk to us a little bit about
What?
just a background of what it is?
Oh, okay. So we know that from the cervical cancer screening, we have two ways in Indonesia. It's the first one, it's the VIA, which we take a look from the cervix using the acid, so we can see the lesion. The first one. The second one, we can do the cytology, that we have the cervical swab. And the third one is we try to identify, is it this patient already infected by the HPV or not, by using this HPV DNA sampling, doctor. So if the patient is if we didn't find any lesion in the cervix, but we found that this patient already infected by the HPV DNA, we can conclude that maybe this patient have to do their routine screening, because we will have two there's a two ways when someone is infected with the HPV DNA. The first one, maybe it will regress, so the HPV DNA will disappear from this patient after 1 or 2 years. It will self-regret. It will have a self-regression, doctor, after 1 or 2 years. And the second one, it will develop into the precancer lesion, and then maybe it will be a cervical cancer. So we will take a warning if we for the patient with all negative result, we can screen it by only 3 until 5 years better to have a repeated screening. But if we found it's positive, maybe we have to screen it in a 6 month or 1 years. So if it's developed into the precancer lesion, we can do the excision, so the patient will won't develop into the cervical cancer. Thank you.
Okay, thank you so much. Any other questions? Okay, thank you again, Mr. Christian. We appreciate your contribution.
Thank you very much, doctor. Maybe I will close.
Now we're going to move on to the next speaker, which is myself. So today what I'm going to be, and let me just share my screen. So my name is, as you guys already know, is Zainab, and I am an educational psychologist in the States. And today I'm going to be talking about autism, more specifically autism in girls. So masked, and misunderstood, rethinking autism when it comes autism testing in girls. Okay, so let me just, okay. So I'm gonna go ahead and get started. All right. So today I'm going to go over the diagnostic gap between diagnosing females versus males when it comes to autism, the female autism phenotype, masking and camouflaging, misdiagnosing, and rethinking assessment. So what we need to do in the future when it comes to testing. Now, autism is often misunderstood before it is understood in both female and male cases, especially because we now have more research. We have better diagnostic tools in order to diagnose autism. And it is not the stereotypical way that we see autism, whereas, before if someone would not give eye contact at all, or was nonverbal, or displayed severe repetitive behaviors. We now know that autism is a spectrum, and it's a lifelong neurodevelopmental condition, and it affects how individuals communicate, interact with others, and experience the world. And according to the DSM, which is the diagnostic standards that we use when we are diagnosing autism, autism is defined by two areas of difference: social communication and interaction, whether that is language, the pragmatics of language, the back and forth, the reciprocal conversations, restricted and repetitive behaviors. These look like intense interests, sensory sensitivities, those kinds of things. Okay. So here I want to talk a bit about the diagnostic gap. I have been purely working in testing for the past 4 years. And just from the time that I first started until now, we have learned that there is a huge gap, especially with females. And girls are not less likely to be autistic, they're just less likely to be diagnosed in childhood. So on average, girls are diagnosed 4 to 5 years later than boys. And why is this a problem? This is a problem because, as we know, early intervention is key. So delaying the 4 to 5 years of any kind of intervention might lead to other mental health concerns, which I'll get into as we go through the presentation. Now, different research has showed that girls present with fundamentally different autism symptoms, and that the current measurement tools have built-in sex bias. So they were predominantly established based on male characteristics more. And again, we're going to get into that in more detail. Now, again, why is this a problem? It's a problem because the system fails girls. So when a female comes in and we are diagnosing or we are doing any kind of testing, a lot of times we have to do some extra testing, or we have to do some additional questionnaires or based on our observations. Like, for example, when playing, a kind of repetitive behavior is lining up toys or lining up objects. What we see in a lot of females is maybe not necessarily lining up objects, but setting the scene. So I'll give them some dolls and some, furniture and things of the house. And what I often see is, or what I commonly see in girls who are on the spectrum, is they will set up the scene, but they will not interact with the toys. So that's kind of one observation that we notice. So even though technically they're playing, we look at what kind of play are they being involved in. Okay. So let's look at the female autism phenotype. It's a different presentation, not a milder one. So it is a pattern that is shaped by biology, socialization, and the diagnostic lens through which we look. So what are we missing? We're missing social difficulties tend to be more subtle in females or more context dependent. So let's say with individuals that they feel mostly comfortable with, such as, for example, family members, mom, dad, or siblings, we might see them interact more in those situations as opposed to at school or in other environments, such as like extended family gatherings. They have a stronger motivation to fit in and socialize, even when it can be mentally and cognitively draining. And we're going to talk about masking and camouflaging next. We're also missing the restricted and repetitive interests because girls tend to have restricted interests that appear to be more socially normative, but are equally intense and rigid, such as things related to celebrities, relationships, animals, fashion, etc. We're also missing the internalized repetitive behaviors. So a lot of the times, again, it's more internal. So we might not see it such as hand flapping, jumping up and down, hand twirling, flicking in front of their eyes. So we might see it more along the lines of rumination, mental rituals, etc. So how can we test for that? We usually kind of ask questions or prompt questions, and sometimes it is very difficult to identify those repetitive behaviors, especially in females, when they aren't visible. Another thing that we are missing is that for females who have strengths in verbal communication or demonstrate good eye contact, they're flying under the radar. And I'll get into this more when we get into the testing. So, what do clinicians often mistake as ruling out autism in girls? A lot of times, if they think that, this girl can maintain friendships, um, or if they can make eye contact, empathetic, has socially acceptable interests, is verbal and articulate. So, a lot of the times when a girl comes in and they are looking at all of those, what they don't realize is that these traits are actually related to autism. Okay. And I want you just to think about how many times just in your practice or family members that you've seen where you said that this person is not autistic because they are too social. And we're going to talk about again, we're going to talk about the masking and camouflaging and the hidden cost. What is camouflaging? Camouflaging refers to the behavioral and cognitive strategies that autistic individuals use to hide or compensate for autistic traits in social settings. And it usually comprises of three components: masking, which has to do with suppressing or hiding autistic behaviors. So things like suppressing stimming behavior, so repetitive behaviors using the body, or forcing eye contact. And I hear that a lot. And one of the questions that I'll ask during the evaluation is, how do you feel about eye contact? Do you find it to be comfortable? Do you find it to be, is it something they have to think about? And a lot of times you'll see that it's a learned behavior. Compensation is something that I see very often, is using explicit strategies to navigate social interactions. So here we're talking about scripting conversations. We're talking about even memorizing social rules, not only social rules that they've observed from family members or others, but also those on TV. I worked with a few adults, and the common, when I'm asking them, how they navigate social interactions, and again, asking them, how do you feel about social interactions, and how did you interact when you were younger? A lot of them say that they would stand in front of the mirror before going to school or before going to an event and rehearsing a lot of the things that they should be saying, or, if someone were to ask them a question, how could they respond? And when they get to the actual social interaction and when they're being asked questions, if it steers off of the track of what they had initially in their mind, they let me know that they just don't answer. They don't know how to answer because that wasn't a part of what they rehearsed. So again, here we're talking about a lot of mental or internalized symptoms that come into play. Assimilation, the feeling of pretending, of acting, trying to pass as neurotypical. Some common statements that I get told is, I always felt like I've been different. I've always felt like I've been the odd one out. I don't know, I just feel a bit awkward. So a lot of those things of not fitting in is what we hear a lot of the times. So they've kind of found a way or, to kind of pretend. And a lot of times it is extremely exhausting. Now, I'm just going to go over these quickly. So based on different studies, what we see is that autistic females score significantly higher on camouflaging measures than autistic males. And what we also see is that the reason why there are less diagnoses, again, isn't because girls are not autistic. It's because they're so good at camouflaging. Their brains have found ways to mask, to find what is socially normative and go through there. Now, with masking and camouflaging and everything, what is the cost of it? And there's a psychological cost because camouflaging is an adaptive coping strategy. It's not an adaptive coping strategy. It's more of a survival strategy. And with that survival strategy, we have consequences. So it significantly increases vulnerability to anxiety and depression or autistic burnout. It contributes to delayed diagnosis. So traits are hidden precisely during assessment. And there are times where we've had to have 2, 3, and even 4 sessions just to really kind of understand whether this girl is on the spectrum or not. And we do a whole comprehensive neuropsychological evaluation. And it also creates a cycle, which I have on the screen, of, the better a girl masks, the less likely she is to receive the support. So the less support she receives, so the more she must mask. And it just becomes this cycle of not receiving the report and then the support and then reaching burnout. And chronic masking has been linked to identity confusion, emotional exhaustion, and reduced quality of life. Now, something that's very important because I work with both children and adults. So the youngest child that I've tested is 1.5 years. The eldest client that I've tested is about in their 60s and 70s. Okay. And what I often see, and what research also shows us, is that up to 80% of autistic women are misdiagnosed before receiving their autism diagnosis. And this is something that's very important to talk about because the pathway looks very different. So they might present with anxiety, mood dysregulation, refuse to go to school, struggle with eating. So again, with like the sensory aspect of eating, self-harm. And the typical diagnosis that they receive is everything except for autism. So things like anxiety, depression, OCD, ADHD at times as well, borderline personality disorder, OCD's obsessive compulsive disorder, PTSD, so post-traumatic stress disorder, eating disorders. What gets missed is the autism driving the internalizing symptoms. And the consequence is that the treatment is targeting the symptoms without the root cause. There's either partial or no improvement and repeated re-referral. I recently tested, and when I mean recently, in the past 2 months, so just so you guys can see how common it happens, I tested 3 individuals who have been in the testing process ever since they were younger. They've been diagnosed with everything. They've tried treatment for anxiety medication, for depression, for ADHD, for even borderline personality disorder, even bipolar, everything. And they just still, these symptoms, still their quality of life, a lot of things are interfering, the sensory sensitivities, the social aspect. And when we did further testing, we realized that this is actually autism. So you can just imagine what they go through in that cycle of, of feeling like something's going on, but not knowing what it is, and then having to go through all these different kinds of diagnoses. Now, why does this happen? It happens because of diagnostic overshadowing. And again, as I mentioned, just in the past 4 years, every year we're learning new things when it comes to autism testing in girls. And a lot of times what happens is diagnostic overshadowing, which describes how co-occurring conditions absorb the clinical attention, masking the underlying autism. So, for example, a lot of times adolescents, because they're going through puberty, because girls are seen as being more emotionally charged than boys, they might be referred for testing or referred for therapy involving eating disorders, mood concerns, or self-harms, not the behavioral ones. So autism is rarely the presenting question. And a lot of times, girls will come in for testing, or parents will bring their girls for testing. And just through like the intake, and we're asking questions, we'll almost always provide a screening for autism and ADHD as well, but mostly for autism, because we want to see whether that is the actual presenting problem, but we're just seeing it as anxiety. And what's also important to note is that autism and anxiety, or autism and depression, autism and bipolar, they can occur together. So there are high rates of co-occurring anxiety, depression, and even eating disorders. And a lot of times, that would be the secondary diagnosis. So how I like to explain it, especially to adults or to adolescents, parents of adolescent girls, is, because of the late diagnosis, there's a lot of internalizing symptoms which have caused anxiety or depression, feeling left out, or not feeling like, that they fit in. Okay. Now let's rethink assessment. What needs to change? As I first started, I mentioned that the current tools were developed, validated predominantly on male samples. So especially the three that you see on the screen, the ADOS, the ADIR, the RADS, and I often use the ADOS along with the ADIR most often. I also use another kind of testing, which is called the MIGDAS, and it does help with identifying girls who might present with more subtle symptoms or who might kind of fly under the radar. But just to kind of go over, so a lot of these, again, it's based more on the early observable behavior of more, again, male samples, less likely to the subtle or masking symptoms that I mentioned, and sometimes more, more like level 3 supportive autism rather than level 1 supportive autism. And what needs to be done is that we need to integrate camouflaging or masking assessment formally. So what this again might look like is to probe for, asking questions about their compensatory, how they compensate during social interaction. So as I mentioned, sometimes I will ask about, eye contact. And even sometimes we'll have like parents join in, and for older adults, either their partner or someone in the family as well. And I also observe the way that they're interacting with the parent or with someone who they know versus with me. And then that way I'm able to also see. And a lot of times I'll have clients who are quiet the whole time while I'm working with them. But then when the parent comes in, They are talkative. So I can also see that difference as well. And then when I'm asking them a question, are they answering me or are they talking to the other person in the room? Another thing that we need to look at, or what we need to do is to take nuanced developmental histories. So ask parents specifically about early friendship quality, not quantity. I recently tested a little one who the parents said, she's friends with everyone. But then getting to know or asking more questions, she does have a lot of friends. She's very friendly. But the reason for that is because she just follows what others want to do. And she does not lead because she wants to avoid conflict. Okay, so it's very important that, again, we look more about, exhaustion after social events or after a long day at school, because oftentimes a lot of girls, they might, put on a brave face the whole day at school, but then they come home, they have meltdown, or they become emotionally dysregulated, or we see a difference. Again, at school, perfect, no difficulties, listening to the teacher, fine with friends, but then the second they walk in the door, you might see crying again or meltdowns. And then you can see that, okay, there's something going on, something deeper. We need to look beyond, beneath the surface. Considering gender-specific supplementary tools, more awareness as well for professionals in the field to screen girls with gender differences in mind. So any kind of doctor, or anyone just kind of being able to screen more, better clinical training for female autism, and referral pathways for girls should be different from those for boys. So if there's any concerns, there should be at least a screening. That way we can know whether we need to do a full comprehensive evaluation or just keep it at that. And here are some things I want you to take away and take into your practice is that the diagnostic gap is not about prevalence. It's about detection. We need better detection tools. We need to be more aware of those subtle differences between girls and boys when it comes to autism. Girls are autistic at higher rates than we do diagnose. Females are missed. Masking is not resilience. It's actually a costly survival strategy where at the end of the day, they just become burnout, become emotionally, physically, cognitively exhausted. A lot of times, or a few cases where I've seen females just give up. They can't work. They physically cannot get out of their house and go to the grocery store. And that is because, again, they're just exhausted. They've used masking as a survival strategy. And it just gets to the point where they just can't do it anymore. And the misdiagnosing cascade is predictable and preventable. And the current tools are biased, and our awareness of that bias is the first step to equity. So the statement I want to leave you guys with is that we are not seeing fewer autistic girls. We are failing to see them. Okay. Any questions? Okay. If no one has any questions, we can end today's session. I want to thank everyone for their participation, all the speakers for your support and participation in day 2 of the virtual session. I also want to encourage everyone to join us for our future upcoming conferences. Thank you again for joining us.